Good morning, good afternoon, or good evening, whichever time it is that you're watching this. I'm not 100% sure how these are being recorded, but I appreciate you joining this talk. This talk is on ACL injury prevention or reduction type of programs. And you see I'm blocking out prevention. I'm going to talk about in a few minutes of why I'm blocking this out. But I certainly want to thank the committee member for the Apta Next annual conference who's allowing us to do this session for you. I have to thank several other speakers that have helped me a lot in my career. One is Walt Jenkins, who put this together. The other is Terry Malone, who's in the middle of the picture here. And then, of course, Gary Calabrese, very good friend from Cleveland, who helped me a lot with this presentation. So thank you all, especially Gary. So we're going to talk about injury prevention or reduction programs. And to be honest with you, before we do any talking about injury prevention, I think we have to thank this guy. This is Tim Hewitt, the ACL Elvis, and I call him the ACL Elvis because he's kind of the king of ACL prevention type programs. This guy has written more and studied ACL prevention more than anyone probably in the world. So a lot of his work I'm going to talk about here, and without him, we wouldn't know really anything that we know about prevention or decreasing the risk of ACL injury. So thanks, Tim. You're awesome. So here's my objectives for today. I want to discuss current effective ACL injury reduction programs. I want to talk about how to implement these programs for injury reduction. I want to talk about some of the psychological effects of ACL injury, not only ACL injury, but risk for second ACL injury. Try to discuss a few ways that you can assess this psychological and physiological readiness of someone to return to athletic activity, and then maybe briefly, very briefly, some secondary injury reduction programs and how they can be implemented. So as we all know, the injuries to the knee are hugely common. I mean, this happens to a lot of people, 1 in 35,000. If you work in an outpatient physical therapy clinic, you're going to see knee injuries, and ACL injury is certainly one of the most common of those injuries. 200,000 athletes sustain ACL injuries every year in the U.S., and the majority of those end up having rehab, and we see patients for that constantly. We used to think that we could get people back to sports and back to recreational activity really relatively quick, anywhere from 6 to 9 months. And what we know now, now that we have better longer-term follow-up studies, we know that really less than probably 50% of those people return to sports in 1 year after their ACL reconstruction. So we're not returning people as fast as we used to think we are. And I think that's a good sign. We really need to wait a little bit longer and not let people go back too soon. When they go back too soon, there's a higher chance that they're going to be re-injured or injure their ACL a second time or injure their other knee the first time. And as you can see, depending on the literature, 20 to 25% of those people will sustain a second knee injury, which is certainly not what we want or what they want. This is why I put the line through prevention earlier in my talk, is because we're really probably not preventing ACL injury with training or anything that we're doing. We can't prevent it. We can decrease risk, but we can't prevent. If you look in Webster's dictionary, prevention means the description of what prevention is the act of preventing, and preventing is to keep something from happening or existing. So prevention, we used to call these prevention programs, but we're really not preventing anything. It's a really misapplied. Calling it prevention is misapplied. We really can't prevent them. We can decrease the risk of someone getting injured or someone tearing their ACL or re-tearing their ACL, but we can't prevent it. It's probably going to happen to some people regardless of what we do. There's too many reasons for it to be able to occur, too many varied factors, and so completely preventing it is almost impossible. So when we look at ACL injury reduction programs, we have two types. We have primary, which is really for the person who's playing sports but hasn't injured their knee yet. So it's an ACL injury reduction program. And then secondary, after they've injured their ACL, before they go back to sports or while they're reintegrating back into sports, it's a secondary re-injury reduction program. So after they've been injured, trying to keep them and decrease their risk of having a second ACL injury. Well, Sugimoto, he didn't describe these, or they didn't describe these as pillars. I described them as pillars of ACL reduction. I think they call them principles of ACL reduction, but these include age, biomechanics, compliance, dosage, feedback, and exercise. And I want to go over each of those briefly. So one of the proponents or pillars of ACL reduction is age. And most of the studies have shown that the earlier you start these training programs, the earlier the age is that you start neuromuscular training programs, the less likely someone is to have an ACL injury. So the sooner we can start them at a younger age, the better. Fewer ACL injuries occur in athletes who start them at an earlier age. Now that's when compared to, that's looking at studies who compared people that were older when they started their neuromuscular programs compared to those that are younger. It's not that if you're older, it's not going to help and it's not going to work. It just is going to work better and help more people if you can do it at an earlier age. Well, second is biomechanics. We know that faulty biomechanics at times can lead to the knee or trunk being in positions that can increase the incidence of them tearing their ACL. And probably the biggest one, the biggest biomechanical fault that we see is valgus collapse at the knee. Now, the valgus collapse at the knee, again, can occur for multiple reasons, but it's a valgus angulation of the knee during the sporting activity, whether it's during a plant cut, whether it's during a stop, landing from a jump, multiple different times, your knee can be put in that position. Now, that isn't to say that no one can ever get their knee in a little bit of valgus. Okay, we know that you can tolerate a certain amount, but there is a certain amount that's not tolerable. And that is one of the strongest indicators of increased risk of tearing your ACL is having excessive valgus angulation at your knee during functional activities. What about compliance? Compliance of programs has been shown to be critical. And there's a compliance rate where it works and then it doesn't work. Okay, or it's the compliance rate. There's a certain compliance rate where it's very helpful, and then there's a certain compliance rate that it's not. And that compliance rate is around 66%. If you have a compliance rate of your athletes doing their ACL reduction program of 66% or more, they have a decreased injury reduction rate by about 82%. So that's a pretty significant decrease in their incidence of or their risk of injury or their injury rate. If the compliance is less than 66%, you still have a reduction, but the reduction drops to 44%. So it's almost a 40% drop in their reduction rate just by doing it, incorporating the program less than 66% of the time. So compliance with these programs is a very critical component of doing it. They have to do the actual exercise. They have to do it at a certain amount to see the changes occur. Okay. Next is dosage. We don't know the upper level of dosage, but we know the lower level of dosage. And the lower level of dosage is about 20 to 30 minutes a session. Okay, so each session where they're doing their strengthening, they're doing their plyometrics, they're doing their stretching, they're doing their exercises, needs to be a minimum of about 20 to 30 minutes. And this needs to be done several times a week. There have also been studies showing that it's better if it begins in the preseason, so starting before the season even starts, early in the preseason, and continuing throughout the season. So not stopping when the season starts, but continuing it through the rest of the season, or at least as long as you can through the season. So 20 to 30 minutes each session, at least minimum, several times a week. Remember, your compliance has to be about 66% or more than 66% for it to be most effective. It's still effective. I'm not saying it's not effective at all. If it's less, it's still going to be helpful and effective, but not as effective as if it's done at least 66% of the time or more. And again, several times a week, better if it starts in the preseason, and better if it continues throughout and into the season. Feedback, that's the fifth pillar. Feedback requires some type of cueing whether it's verbal cueing, whether it's looking at mirrors, whether it's videos, some type of cueing to tell people what they're doing wrong, what they're doing improper, what mechanics they're using that are faulty, so that they can see it, they can hear it, they can feel it, and try to fix it. And it seems best if you use an external focus in your cueing. And by an example, a good example of external focus is, not just tell them to not let their knees fall inward, but tell them to, something along the rate of keep your knees toward the outside walls when you land. Okay, so it's giving them an external focus of control as you talk to them about their giving them feedback. And the last is exercise. Exercises in different programs. There have been many different types of programs. I'm going to talk about a bunch of them in just a minute, very briefly. But these have been looked at individually and in combination. They include plyometric, neuromuscular, and strength and conditioning. These have been looked at individually and in combination. And most of the studies that have looked at them in combination have found that a combination of these three factors are most beneficial. Again, any one of these type of exercises, plyometric, neuromuscular, strengthening, are going to be beneficial, and they're probably going to help to some degree, but you're going to get the best bang for your buck if you can incorporate all three of those into your programs. So I apologize for the Coors Light beer in my hand, but I don't know how many people of you know this guy in the blue shirt, but I've got his name highlighted below. His name's Steve Vequist. Steve, Kim Yearout, and Dean Griffiths are actually the three of the five that actually started what they called injury prevention programs. Clear back in 1989, it was a very minimalistic approach to injury prevention. What they did was they did training with individuals before and after they were injured. And they did three simple things. They did bent knee landings. So they had people trained doing jumping and making sure they landed with a bent knee. They did, instead of like a one-step quick stop, they did like a stutter step stop, where you took multiple steps, 3 or 4 steps to stop rather than stopping immediately. And they taught people how to do rounded corners. So taking short steps when they were doing cutting, instead of planting and cutting with one step, they did rounded corners for their cutting. In this minimalistic program, I don't remember how long they tracked it for, but they had a fairly significant, I think almost an 80% reduction in injury rates in people that did those type of training. So again, it was very, very basic. First, probably, this wasn't even published. It was just presented at one of the AOSSM meetings, but these guys were some of the leaders in looking at injury prevention. Dr. Henning, Charles Henning, was the surgeon that helped them with this program that they worked for at the time. But this is Steve Vequist, great guy from Wichita, Kansas, by the way. All right, so we can see here, this is a study I'm going to talk about in just a moment, but the reason I have this slide here is because there's studies down below have showed that there's 11 systematic reviews published every day. So 11 systematic reviews published every day. It makes it very difficult to keep up to date with all the latest literature. Therefore, nowadays there are overviews or reviews of reviews, or you can see here a meta-analysis of meta-analyses that are being done, looking at the different literature and trying to pull everything together to give us a very good understanding of what the literature tells us. So this is one of the more recent, published in 2020. They looked at 8 meta-analyses about injury prevention, ACL injury reduction training programs. 6 of the 8 of these studies were usually females only. And their summary analysis, those showed overall a 50% reduction in risk of all ACL injuries, so 50% reduction. However, it was higher for non-contact ACL injuries in females, up to 67% reduction possible by doing various injury reduction training programs. And unfortunately, there were only 2 of those studies that included males. So they came to the conclusion that there was insufficient data to determine effectiveness in males only. However, I've got a couple more studies in just a few minutes I can tell you about that have looked at males. This was published in 2018 in Archives of Orthopedic Trauma and Surgery. It's guidelines for prevention of knee and ACL injuries, published in 2018, but written up in 2017. And you can see there's numerous factors or risk factors for tearing your ACL. And the majority of those are non-modifiable. And really, we can't do anything about non-modifiable risk factors. There's nothing we can do about those. But however, we can do something about these, the modifiable risk factors: dynamic valgus, low flexion of hip and knee during landing, poor hip and trunk control, weakness of knee flexors and abductors, delayed activation of knee flexors, proprioception deficit, muscle fatigue, and poor general fitness. That's where we got to put our money. That's where we got to put our stock in place, because we can do things about that. We can do training for that. We can do biomechanical training. Again, we can increase fitness. We can increase strength. We can increase neuromuscular control. We can increase balance. We can increase trunk strength. We can do everything to try to improve all of those type of things. And that's what the reduction programs are going to be about. So here's a couple more studies looking at effectiveness: 52% risk reduction in females. These several studies set up to 85% reduction in male athletes. The problem is that there's multiple programs. No standardized program has been shown to be superior to others at this point. I already mentioned that preseason program and in-season maintenance is very beneficial. You want it to have all the components. I mentioned that too. You want it to be at least 20 to 30 minutes per week. And then the people involved are typically around 12 to 25 years of old. And then I already talked about compliance. So here's some limiting factors. Some of these we talked about. Compliance has to be 66% or more to get the biggest bang for your buck. Some of these cost money. Not everybody has money to pay for these. So there's certain ones that cost money, certain ones that are free. So there should be some type of training for everybody, okay? You have to look at feasibility, you have to look at the fatigue of the individual, and then certainly you got to get the patient or athlete buy-in to do these programs. This is what successful training components include: flexibility, dynamic strength, dynamic balance, plyometrics, body awareness, trunk control, conditioning, sports-specific skills, and decision-making. Talked about a lot of that already. That's what a holistic program will include, those different variables. So here's your different types of programs. We have the ACL Injury Reduction program, and then we've got several that also span the gamut that are ACL Injury Reduction and performance programs as well. So Sportsmetrics is one of the first that was done. You can see the duration of time that it takes per session. It's usually done in the preseason. Typically, you take a therapist or trainer would be certified in giving this program 3 times a week for up to 6 weeks. Here's what it includes. The strengths are sport specific. It's very comprehensive and progressive. It costs money, so there's usually some financial consideration. And here's the performance activities that you do, which pretty much cover everything that you can see with that program. The prevent injury, enhance performance is shorter duration, which may be good. Includes a warm-up, static stretching, leg strengthening, balance, plyometrics, and agility. These are done with videos. They're usually done with younger athletes. The strength of this is it's fairly quick, it's accessible, it's feasible, and again, it's fairly comprehensive. Weaknesses may be a lack of progression that occurs with this program, lack of hip external rotator strengthening, abdominal back strengthening, and or dynamic flexibility. However, it is very good for lower extremity strengthening. The FIFA 11 is really a soccer-specific program. Again, it's fairly short, about 20 minutes. You do it with a warm-up, static stretching, leg strengthening, balance, plyometrics, and agility are all included within this program. It's quick, it's accessible, feasible, comprehensive, and it is progressive. And I'll show you what I mean by that in nature. As I mentioned, it's developed for soccer only. You do lower extremity strength, abdominal strength, power, and endurance. So here's a couple diagrams showing the FIFA 11. So it starts out 8 minutes with running and kind of warming up type exercise. You got about 10 minutes of strengthening, plyometric, and balance, and then 2 minutes at the end of different running type exercises. And you can see, here's your running exercise. I apologize. Here's the strength, plyometrics, and balance, and you can see the progression of them from level 1 up to level 3. Obviously, level 3 is a higher level, and you progress through those stages to get to harder, higher level activity. So it is very progressive in nature, which is one of the positive components about it. So when you talk about it, we talk about implementing these programs. I mentioned some of this before. If they start the training in preseason and continue during the season, it's probably going to be more effective than performing it only during the competitive period of the training or the season, or doing it only before the competitive period. And then I mentioned earlier, longer duration program, usually more than 20 minutes is required. And again, I don't know that we know for sure. We know the lower levels. We know it needs to be 20 to 30 minutes or more. We don't know what the top level is. We don't know if it, you get more of a bang for your buck for going an hour and a half and you do an hour. You get a better buy-in and less injury if you do it for an hour versus the 20 or 30 minutes. I don't know that we know that. That's still yet to be seen. Well, what about coach-led injury reduction programs? There's several studies looking at how well coaches integrate these into their program and whether that seems to be beneficial. This is a study done by Frank, looking at injury reduction workshops, and supposedly the coaches that did these training programs said it increased their attitude, comfort, and confidence. However, this is fairly problematic. It didn't really translate to their implementation of the program. Only about 53% of the coaches implemented their injury reduction program, even though they were trained and did workshops on those programs. And the number of individuals that did incorporate them really varied. Another study looking at neuromuscular training for young athletes, comparison of coach and athlete compliance rate. This is a totally different study, different group of authors. They looked at the compliance of both the coach and the athlete with neuromuscular exercise for injury reduction. They looked at 52 teams, 547 female athletes. Coaches participated only about 50% of the time. So it's very similar to the study here by Frank. Only about 50% of the time did the coaches participate. However, the athletes really better off, did 88%. 88% completed at least 2/3 of the required visits. So the athletes performed the compliance as you would like them to, about 66%. 2/3 would be 66%. Physical therapists, athletic training led programs, athletes' willingness. There's a couple studies looking at the athletes' willingness to perform the injury prevention program. And believe it or not, improving performance wasn't really one of the main things that they looked at in their willingness to perform the program. It was really looking at it for a decreased risk and injury. You'd think that maybe they wouldn't buy in and maybe they would only want to do it if it improved their performance, but that's not what these researchers found. If you educate the athlete on why they're doing these programs and how it's going to benefit them, I think you'll have a better buy-in. Again, the program needs to be formed consistently, starting while they're young. I've already mentioned that several times. So this is what Gary told me they do at the Cleveland Clinic. They have an injury prevention program called Match Fit, where they use both PTs, PTAs, and athletic trainers. This one is soccer specific. It lasts about an hour, one time a week for 8 weeks. You can see the different activities they do: core strength and motor control, jump mechanics, power, agility, and speed. So they pretty much cover every gamut that needs to be covered to be a beneficial injury reduction program. So they hit all the, check all the boxes that are needed to have a good injury reduction program. They do flexibility, strength, motor control, jump mechanics, plyometrics, agility, and then soccer specific drills. Some of the tips to be able to incorporate these are certainly have cooperation between the coaches and or the athletic trainers and or the parents, depending on where you're putting these programs on. You need to have some space, obviously. The timing of year is going to be critical, whether it's done indoors or outdoors, and whether you have the availability to have space indoors, so like in the winter, to do these programs. Make sure everyone knows the expectations, not only the athletes, but the coaches and the parents as well. And then ensure they understand what they need to do at home on their own. If these are only done one time a week, they've got to be responsible for some of the program parameters that they're doing in the meantime between when you see them once a week. One of the last things I want to talk about is re-injury reduction. So following ACL reconstruction, Arden has shown us that during a return to sport, functional performance has several critical factors. One are physical factors: strength, pain, stability, swelling, joint swelling, and range of motion. But you also have psychological factors and social contextual factors. The psychological factors are the patient's or the athlete's motivation, their fear of new injury, and their readiness to or not to return to activity. The social contextual factors are recovery expectations, their injury history, family history of injury, their quality of life, and satisfaction. All those funnel down into functional performance and are needed to be at adequate control for them, adequate level for them to be able to return to sport. So athletes, after they tear their ACL, and we see this quite often, I'm sure you do too, a lot of times they're depressed, they're very anxious, they're not sure about the injury, they're not sure if they're going to be able to return to their injury. A lot of instances they lack confidence, they're worried about re-injury. Certainly they lose an identity and purpose. If they've been playing sports all their life and that's what they're known for, they're going to have a significant loss of identity or purpose. And then, when they're injured like that, they don't, or to some degree isolated from the team. And really, they're maybe not isolated completely from the team, but they may feel they're isolated from the team. And from what I can tell you, and again, you've probably seen this yourself, these aren't always the people. I mean, when you first meet these people, you think some of them are pretty strong, they're pretty tough, but you realize deep down they're not as tough as they act like they are. And a lot of them have a lot of these worries and a lot of these concerns that we need to talk with them about and try to make sure they understand, that this injury is a part of athlete's life and that you can recover from it. And it's not necessarily a death sentence. That they're not going to be able to return to sport. But they've got to be able to be open and willing to talk to you about that. And you have to be able to talk to them about it too. A lot of times they have higher expectations and they're not really sure about their commitment to rehab. And a lot of times I don't think they're mentally prepared. They don't understand what the rehab involves, the length of it, and the seriousness and the amount of time that it's going to require. Well, fear of re-injury is one of those things that keep them back. I don't think fear of re-injury is really, we used to think that fear of re-injury is what caused a second injury. I don't know that it's fear of re-injury that causes a second ACL tear. I think fear of re-injury is what keeps them from getting back to their prior level. One of the most common reasons why one doesn't return to sport at their previous level, they're scared of injuring their new reconstructed knee or their contralateral knee. And depending on what study you see, either one of the knees can be injured. And what we do know is that if you have less fear of injury, you're more likely to return to a higher level. Now, that isn't always great. A good friend of mine, Mark Paterno, just did a study, they presented a study at a combined section meeting, in 2019, where they looked at the females, their score, their amount of fear, and what they found was that the ladies that were not scared to return actually had a higher risk of being injured than those who were scared. So if you weren't scared and you thought you were doing well and you thought you could return to a high level, that actually increased your risk of re-injuring, having a second ACL injury. So we do worry about them having fear of not returning, but at the same time, it should be a concern if they're not worried at all. If they're not fearful at all, they're probably pushing it harder and putting themselves in positions that maybe could result in injury. So how can we help the athletes with these psychological aspects of their ACL injury? Well, certainly we can help them talk about personal control and control of their situation, control of their injury, control of their rehab. Through rehab, we can give them confidence in their body, through graded exposure and gradual progression of their rehab activity. That will hopefully give them a sense of connection still with their coaches and teammates, or hopefully they will still feel a sense of connection. And we have to get them to believe in and buy into the rehab process. And a lot of times it's really nice if you see a lot of people that have these injuries, because usually you have someone who's further out in their rehab process. And And if they're doing well, they can be kind of a role model for the person who was just recently injured. I think that's very helpful for them. Another outcome measure we can look at, a psychological outcome measure, is the ACL RSI, and this evaluates the psychological readiness for an athlete to return to sport. It's a simple 12-item scale, addresses emotions, risk appraisal, and confidence to return to activity. Here's what some of the questions look like. A higher score means they're confident. A lower score means they're more nervous or less confident. And as you can see from this study by Langford and Webster, the scores throughout time, if you looked at the entire sample, their scores are lower than those who return to competition, which you see in the middle column, which are significantly higher than those that didn't return to competition. And then of those that do return, you can see those that gave up sport have significantly lower scores than those who plan to return at 10 months, are doing training at 12 months, or fully competitive by 14 months. So it seems to do a very good job of finding people who, looking at their concern or fear to return, and those who have less fear and higher scores are more likely to be those that return to sport. So again, what are some tips overall? You want to use a team approach. You want to have as many people as involved as you can, and that includes the injured athlete, their family, the coaches, the athletic trainers, and certainly their surgeon. So making sure that they're all aware of what's going on. Make sure you include the athletic trainer and keep them involved. So when you're not seeing the athlete in the physical therapy clinic, they're seeing them as well. Make sure you involve the family. You want to make sure they're doing weekly exercises. Make sure you make them accountable for their program, but try not to be negative. Always be encouraging for them, and then regularly assess both physical and their psychological readiness to return to sports and athletics. So again, with that, I'd like to thank the APTA for allowing me to provide this session with Walt, Terry, and Gary, and I hope that you got something out of this, and hopefully I will be able to see you live and in person sometime in the future. So thank you very much. I appreciate your attention. Have a good rest of the day.